All right, so the topic for the day is anemia, and it'll take me a little while to ignore the camera, but eventually I will ignore the camera. By definition, anemia is a condition where there's a decrease in either the number of circulating RBCs, the amount of hemoglobin, the volume of RBCs per 100 mils, or a combination of these, okay? So it's not uncommon to have a combination. When a patient has anemia, it leads to hypoxia. Hypoxia is what accounts for the clinical manifestations. Most of the clinical manifestations. There's some other clinical manifestations that occur with anemias that are related to other components, but most of the time it is the hypoxia, or not most of the time. It is the hypoxia accounts for most of the clinical manifestations, we'll do it that way. So this picture is available in the assessment chapter, hematology assessment. So, you know, the chapter probably just ahead of this one, which provides a nice basis of things. But if you look at plasma, like when they stick your arm and they draw blood, okay? We're made 45% formed elements and 55% plasma. If you consider what plasma is water, protein, and a few other things like, okay, those things. And then the proteins, most of it's albumin. That's why when we talk about oncotic pull, the ability of plasma to stay in a particular space, it's because of the protein, in particular because of the albumin. Globulin and fibrinogen also support the protein number, but even the form, the kind of protein that those are, do not have as much oncotic hold as the albumin does. So there's your plasma part. And then the other stuff, the formed elements, are red cells, white cells, and platelets. Okay? White cells can further be differentiated into neutrophils, lymphocytes, monocytes, eosinophils, and basophils. So this really does a nice job of helping you to see what all is floating around in your bloodstream. If you consider what happens, how red blood cells mature, how cells in general mature, you look at starts at the bone marrow with a stem cell. And the stem cell can differentiate into an erythroblast, a myeloblast, a monolympho, or megakaryoblast. Okay? Blasts are baby cells. That's what blasts are. So when you see a boatload of blasts on someone's lab, you have to wonder what's going on. That's not normal, because these blasts, they stay in the bone marrow until they get to a certain place of maturity, and then they're sent out. Of interest, you know, normally when we think of things maturing, we think of them growing and getting bigger. Red cells, the cells of the hematological system, when they mature, they get smaller. So that's kind of important to kind of stick back there, because anytime you see megaloblastic anemia, that suggests that it's a maturational problem with the cell because the cell is big. Whereas microcytic, something's missing, and so that cell is smaller than it should be. So just, you know, for example, pernicious anemia or your vitamin B deficiency anemia, those are mega, whereas your anemia of iron deficiency is a microcytic, because you're missing the iron, which helps the final product have some size to it.
So does that mean that there's an issue with growth when you were
Growth of the red cell.
But for whatever reason, that's the sign of the disease, that there was an alteration in its growth pattern, whether it got smaller or it didn't mature.
Yeah. For example, if I have a vitamin B12 or folic acid deficiency, vitamin B12, folic acid are necessary for RBC maturation. So if they don't mature, they stay big. And so the anemia, I have pictures of those when they come up, you'll see. The anemia of vitamin B12 and folic acid produces megaloblastic cells, whereas the anemia of iron deficiency. Iron is towards the end of maturation, and it's in the cell. If it's not there, it makes a little cell, so they're microcytic.
So they're smaller than the normal cells.
Yeah, because the iron's not there. But see, here's your normal red cells. See how little they are?
Yeah.
You know, so in a microcytic anemia, they're even littler. But if it's a megaloblastic anemia, they may look a little bigger because they're not fully matured. It's backwards. Things that mature are supposed to be bigger. But in this system, things that mature generally get smaller. You can see from here that the erythroblast goes straight down from bone marrow to blood to the RBCs. A myeloblast further differentiates into specialized white cells. And then know that your neutrophils, the metamyelocyte, first produces a band neutrophil, and then as it matures, the bands become segmented. Here's the band, and then it becomes segmented with maturity. I say those words because you'll hear them in the clinical setting, or you'll read about them. It'll say segmented neutrophil. Well, what is that? It's just a mature neutrophil versus a band neutrophil. What's that? Well, the band is immature. You really shouldn't be seeing hardly any of these on a differential. When you see band neutrophils, it suggests that there's an infection going on that's overwhelming the big guys, and so they're sending babies out to war. Not a good strategy, because there's probably something about the banding that makes this neutrophil more effective in doing its job. Band neutrophils are not as effective, probably because something about the segmentations, and I really don't know that. Then you also you also have monocytes, lymphocytes, and these, remember, go out into places like, if you did your immune chapter, they're more out in the tissues. They're not just in the bloodstream. And then your megakaryoblast produce thrombocytes, which are platelets. So thrombocytes are platelets. Anemias can be caused by a variety of things, and we can put the causes into 3 general categories. We can say that either there's a problem with production, there's loss, or there's a problem with destruction. Okay, normally a red blood cell lasts about 120 days or so, but if something's going on that's causing the red cell to be destroyed sooner than that, then there can be developed an anemia. So what do red cells do? Well, they transport oxygen from lungs to the systemic tissues. Did anybody look at the video that's on Blackboard? It has to do with oxygenation. It's a nice little precursor. I really meant to send out a message that said, take a look at that ahead of time. It's all of about 2 minutes. But it's a nice little visual that tells you, what's the point? Why do we have red cells? Transports oxygen, carries CO2 from tissues to lungs. A patient who has an anemia, it's not a specific disease. Rather, it is a manifestation of some pathological process. There's something going on that's producing anemia. And then the way that we determine what kind of anemia it is, a lot of that has to do with the lab data. Your clinical manifestations, those are caused by the body's response to this hypoxia. We can say something about the severity of the anemia by the level of hemoglobin. We'll see some integumentary manifestations pretty soon. The cardiopulmonary manifestations, those are additional attempts by the heart and lungs to provide adequate oxygen to the tissues. Cardiac output is maintained by increasing heart rate. This content used to be placed in the 4th semester, and I always did the cardiovascular system first, and then I did anemias. So those compensatory pieces of the heart thing were a little bit better understood, because we had just worked it. But in an anemia, red cells carry oxygen. If I don't have carriers, you don't get the oxygen to the tissues. I can breathe a lot more to try to compensate for that, but I still don't have cars. The cars are the hemoglobin in the red cell to carry the passengers, oxygen or passengers. So if there's a problem with cars, then one of the compensatory mechanisms is for the pump to send the car around extra, and that is reflected in the increased heart rate. If I can get the blood to the tissues and make that car travel more often, then I can make up some of the deficit in tissue oxygenation. This little guy, I don't like him as well as I like my liver man. But if you consider that the body is not getting oxygen, there's a difference between hypoxia and hypoxemia. It seems like we played with this a little bit recently. Maybe it was this morning in clinical, in clinical orientation. What's the difference between hypoxia and hypoxemia? Yes.
Hypoxemia is in the blood, hypoxia is where the tissues aren't getting enough.
Right. So, beyond red cells and hemoglobin, what are some of the other determinants of hypoxia?
Just diffusion.
Okay, perfusion. So you need blood vessels that actually will take the blood with the oxygen to the tissues. How does it get there?
Blood pressure.
Pressure. So you need some pressure. What generates that pressure?
Heart.
The heart helps pump it there. So you have to have vascular integrity. You have to have a functioning heart. Although I would agree that the lungs are not the primary determinant of tissue oxygenation states, they do play a role. If they don't work, you've got a problem. Okay? But if they don't work, there's a lot of compensating that can go on that can kind of help offset that. So lungs have something to do with it too. So if you look at this, you can see your assessments. These are some of the risk factors for hypoxia that include, inflammatory problems. They can be acute or chronic. Complications, cell death, heart and brain most affected. Diagnostics include blood gases, pulmonary functions, if you're looking at, is this a lung problem? Hemoglobin hematocrit, and this is where we're at when we consider anemia. Okay, the clinical signs and symptoms history, pulse ox is low. You have clinical manifestations that are early and late, and we will look at those a little bit more. I can easily put this slide into cardiovascular content, okay, because it's the same thing. Here, this is the piece that we'll be looking at. But all this and all this matters in our assessments. A lot of focus here on pulmonary, which, if that's not the problem, if I'm bleeding out, then having that patient ambulate probably isn't a good idea. At that point, I need to figure out where the hole is and plug it up and conserve energy. So, take some of these into consideration in terms of what is being identified as the problem that's creating the hypoxia. Again, these are looking at consequences, like if I'm having chest pain, and you can have a myocardial infarction because you're very anemic. Usually that patient also has some underlying coronary artery disease that makes them more sensitive to the lower levels of oxygen. If I don't get enough oxygen to go into the heart, I can get rhythm problems. Manifestations are going to depend on the level of oxygen that is being transported and how much hemoglobin there is, then therefore to transport that. A mild anemia is 10 to 12. Patient may get along okay. They might feel kind of tired. They might have some symptoms if they exert themselves. Now when we get to moderate levels, 6 to 10 grams, you're going to see more cardiopulmonary symptoms. Heart rate is a little higher. Is blood pressure going to be soft? Well, do you know what I mean by soft?
It's gonna be higher.
Hmm?
It's gonna be higher.
Maybe, either way. Soft means a little on the low end. It's just a word that's used. The blood pressure, patient's blood pressure is soft. They're not hypotensive in the sense that they seem real symptomatic. Maybe their pressure's 104 over 60. It's a bit soft. That's just a word that's kind of used out there. It's going to depend. What the blood pressure is going to depend on whether this is an acute loss or a chronic loss. If it's a chronic loss, then the body has the opportunity to compensate for the volume. Renin-angiotensin, aldosterone, hanging on to water. I still have to make cells. And if I'm not making cells, then I have a lot of water. I have, at that point, thin blood, in the true sense of the word. And I say that because, we use the words blood thinners. Blood thinners don't really thin your blood. They just interfere with the ability of your blood to clot. And so the blood looks thin. It acts thin. But in anemia, you might really have thin blood because you don't have as much cells in the water. On the other hand, if I'm bleeding out, my blood is as thick as it ever was, I just don't have enough of it. So if I'm bleeding out, my pressures are going to drop, my heart rate's going to go up, and I'm going to see that. Versus if I am losing this blood or not making it effectively over time, compensatory mechanisms will cause me to hold on to water, my volume will be maintained, so my blood pressure isn't necessarily low, and my heart rate might be fine when I'm not doing anything. But the minute I go to exert myself, my heart rate goes up because my tissues want oxygen, and the water doesn't bring you much oxygen. If you go back to that picture that had the plasma, and 45% is cells and 55% is plasma. Of all the oxygen that your tissues get, what percentage of it gets to your cells attached to hemoglobin? Does anyone know? Does anyone know, does oxygen dissolve and float around in the plasma?
A little teeny bit.
Uh-huh.
Much. I thought, is it one hemoglobin off every red blood cell?
It's not the hemoglobin that
Well, the hemoglobin will let the oxygen go.
right. 3% is floating around in plasma. 3% of the total oxygen that your body gets can float around in plasma unattached to hemoglobin. 97% of the oxygen that your tissues get, it gets attached to hemoglobin and delivered by hemoglobin. So if you think about it, if I don't have hemoglobin, I got watery blood, yeah, I can have some of it floating around in the plasma. Maybe that can be bumped up in times of stress. I don't know that, okay? I just know that in general, it's a 97.3. I don't know if there's a compensatory mechanism that allows more to be in the plasma. That'd be a good question for me to find out sometime.
So you said 97% of O2 connects to hemoglobin?
97% of the oxygen that is delivered to your tissues gets there attached to hemoglobin, delivered, released, used at a cellular level. The other 3% floats around in the plasma. Where you see this, when you draw a blood gas, the PaO2 is plasma oxygen. The PaO2 is not measuring oxygen attached to hemoglobin. Does anyone remember the oxygen hemoglobin dissociation curve from A and P? Really not? It's an S-shaped curve that demonstrates that at higher pressures, there is a relationship between how much, see, I'm answering my question already. There's a relationship between how the hemoglobin hangs on to oxygen and where and when it releases it. So, and it's designed so that in the blood, it hangs on to it, and then when it gets to the tissues where the levels are lower, it's able to give it up. Okay? But you do know this. Saturations of 90% are kind of marginal, right? 90% correlates to a PaO2 of about 60. So on your blood gas, when you draw blood gas and you get a PaO2 of 60, that correlates to about 90% saturated. Now saturated is the hemoglobin part. When you check a pulse ox, that's where you're looking at how full the hemoglobins are of oxygen. And when the hemoglobins are 90% full, the PaO2 is 60. What's normal PaO2?
60 to 80?
I think it's 80 to 100.
80 to 100, okay.
I think it's 80 to 100. And that is a pressure, so I think it's 80 to 100 millimeters of mercury, I think. I think it's millimeters of mercury, so it's a pressure. Whereas the saturation is a percent. Now, from 90% saturated to 100% saturated, the PaO2 goes from 60 to 100. That's a big range, right? A little change and a big range. That has to do with the way that hemoglobin hangs on. Then as you move down this curve, more oxygen is given off, or less. I'm not sure now which way it goes. But the oxygen hemoglobin dissociation curve, which I'm very surprised you didn't get in A&P, or no one remembers it, it would have been covered in the respiratory system or in the hematological system.
We got it, we're just fuzzy on it.
Say again?
We got it, we're just fuzzy on it.
Yeah, and it's okay to be fuzzy on it, but that's where, that's where if this patient is at rest, their heart rate might do okay. But then when you get them activity, their cells want more oxygen, and so the heart rate picks up to try to deliver that. Okay, so you see fatigue, because even at rest, they may not be getting everything that they should get. Yes?
I'm sorry, what did you say that the PaO2 correlates to?
60 correlates to 90%.
Before you said that, you were saying something about does it correlate to the unattached oxygen?
Yes, the PaO2 is the plasma float.
Okay.
It's the PaO2, when you draw blood gas, you're measuring the oxygen that's in that plasma.
Okay.
You're not measuring the oxygen attached to hemoglobin.
Okay.
We're just measuring that 3%.
Yeah. And the reason you can say something about the 3% is because there is this correlation based on the oxygen hemoglobin dissociation curve, where in a person who doesn't have acidosis, alkalosis, because alkalosis, acidosis shifts the curve and causes more to be given up at certain times, 60% correlates to 60 millimeters of mercury correlates to 90%. Normal is 80 to 100. So, but if you watch, there's more change from 60 to 80 and less change from 80 to 100. Like 97% might be 80 and 100% might be 100 or something like that. And if I give supplemental oxygen, the supplemental oxygen can boost the PaO2. Like you can have a 300 floating around in the plasma, but that 300 only represents 3% of the total. So it still isn't, I mean, it's better than not, but it doesn't do what hemoglobin can do. You really need hemoglobin to get oxygen to where it needs to go. So in a hemoglobin less than 6, you're going to see multiple systems. You're going to see blood flow diverted to tissues that have higher oxygen needs, away from tissues that have less oxygen needs. Skin is a low oxygen need person. You know, when a person is hypotensive, or goodness gracious, let's just go extreme here. If you do CPR on a patient, does their skin fall off? No. Their skin has a low oxygen need, so it can survive. And so when you have impressive anemia, that's exactly what's going to happen. The vessels to the skin are going to clamp down to get all that stuff to more important places. And so these patients are cool and they're pale. Now, if the anemia is of a hemolytic type, hemolytic anemia. Can anybody define hemolytic for me?
Hemolytic is lysing the cells.
Yes. that the cells are being lysed, they're being broken. And so bilirubin, remember when we talked about the liver, we looked at what happens to bilirubin and iron and all that stuff. Well, bilirubin is released and it causes the skin to be jaundice and the sclera. And it can be hard to tell in people of color, so the sclera is a good place to observe it. And family members often know that that's not right. You know, I may not know that your color is not your color, but family members often do. With the increase in bilirubin comes jaundice. So in this situation, you've got increased bilirubin because more red cells are being broken down. Remember, there's 3 different kinds of anemias. Broad classifications. Decreased production, that's not what we're talking about here. Loss, that's not what we're talking about here. And increased breakdown, that is what produces jaundice. There are some anemias like sickle cell that create a problem for both production and breakdown. So you can have some combinations. Make sense? We're still looking at severe. The eyes can be pale or icteric. And you can develop an anemic retinopathy that closely resembles either hypertensive or diabetic retinopathy. The amount of retinopathy seems to be related to the reduction in the hematocrit or hemoglobin. And it's more common if the patient has anemia and thrombocytopenia, so that combination tends to produce the retinopathies. Anemic retinopathy is almost always reversible if you correct the anemia, and that's a good thing. Still looking at severe, and again, it's going to depend on why this patient has a severe anemia. In the mouth, you may see atrophic glossitis. Does anyone know what atrophic means?
That's really red. It's really red.
It's not the redness.
Without roughness.
Say again?
The muscle is gonna get smaller.
Kind of an atrophy, atrophic. And what's this tongue missing? What do you, it is kind of beefy red, I'll give you that.
Listen up,
The ridges.
Not quite the
It's
ridges.
smooth.
Taste buds.
Those white, kind of the spots, the bumps. Your tongue has bumps on it all over the place. Maybe those are taste buds, I really don't know. But they're kind of missing here. So the atrophic glossitis is kind of inflammation, but glossite is kind of a glossy smooth. It's a glossy smooth tongue. And this is due to iron deficiency. So if the patient is profoundly anemic because they're bleeding out, they're not going to have this. Make sense? Because this is related to something that would be more of a chronic nature. In the cardiovascular system, tachycardia, trying to make up for, if I don't have enough cars, I'm going to send them around more often. Orthostatic hypotension, certainly in acute loss, the more you lose, the more hypotensive you become. But even in chronic loss, can you appreciate that blood that is thinner is going to fall more readily when you stand up? Literally falls. Whereas blood with some viscosity stays in place a little bit better. And what I'm describing is a bit of an exaggeration, but it does kind of work that way. Angina, chest pain, if I'm not getting enough oxygen to the heart muscle, it can be bad enough to actually produce areas of damage to areas of the heart that aren't getting enough. Heart failure. If I don't have cars to drive around and I'm asking that heart to work extra and it's not a good heart to start with, then I can create, and rather than say, well, CHF can happen if this is a long-going thing and you tire the heart out over time, but it can also happen in a more acute way where I don't have a very strong heart, and so when I'm asking it to do this extra work, it acutely decompensates. There's chronic heart failure, which we now just call heart failure. I really should take the C out of there. Chronic heart failure, we now just call heart failure. Although in the clinical settings, they still say CHF. But the other is acute decompensated heart failure. ADHF happens in people who have heart failure and they tip their little totter, okay? Because people with heart failure live on a teeter-totter, one that has not much swing to it. Heart failure is the #1 reason for readmissions, for less than 30-day readmissions on patients, because it's very hard. Systolic murmurs. That's directly due to the blood viscosity. Blood that's less viscous is going to make more swooshing noise. In the lung system, tachypnea, orthopnea, and dyspnea. Neural, these all have to do with just not getting enough up there, right? Make sense? And, you know, we're talking about not getting enough up there because you don't have enough hemoglobin. These symptoms also happen if you're not getting enough up there because your heart rate's too low or your blood pressure's too low. Whatever the reason is that you're not getting enough up there, you're producing a tissue hypoxia. We're talking about the part where the problem is you don't have carriers, but you can have other reasons for tissue hypoxia. In the GI system, especially if the problem is with defective cells that the spleen is having to chew up, that may create an overwork. If the patient has heart failure, then the liver can kind of become swollen, the spleen can become engorged. You can have obstruction of flow to the liver in a hemolytic condition. And the one I'm thinking of is sickle cell. Margaret's covering sickle cell. Okay. Musculoskeletal bone pain. If the bone is trying to make more marrow, not make more marrow, but make more cells, then that can cause, and a lot of cancer patients, when they're getting treatments, will complain of bone pain. Treatments, it's not the treatment necessarily, rather the epigen that they're giving. The treatments cause them to be anemic, and so they end up with epigen, neupogen to make their bone marrow make more cells, and that can cause bone pain.
So is the bone pain from there's too many things in the bone marrow and it's kind of pushing out?
I think it's just from I don't know for sure, but I think it's because the bone marrow is being asked to work way harder than it is and proliferate and stretch and do things that it shouldn't have to do at that rate. So nursing diagnoses, and they're going to depend on what the issue is. Activity intolerance is probably fair for most everybody with anemia. Imbalanced nutrition, well, that's not appropriate if it's blood loss. Ineffective therapeutic regimen management, you know, if the patient needs help understanding what they need to do. And your potential complication would be hypoxemia. Your goals, normal ADLs, nutrition, and minimize complications. Some of the things that we can do are identified here, and you know, of course, they're going to be more specific depending on what the problem is, right? So these are clearly overviews. And we'll talk about more of these as they come up in the different particular kinds. Some gerontological considerations. Anemia is a common disease in older adults. It often grows with just chronic diseases anyway. And some of them, sometimes a patient has an anemia and there's no real identifiable problem, and they actually call it anemia of chronic disease. And a lot of it tends to be related to iron metabolism and stuff like that. But my understanding is that it has a lot to do with just the environment. If you think about the bone marrow and its ability to make cells, it's like a garden, and it really is dependent on having the right nutrients, the right, you know, sunshine and rain, so to speak. And if you're sick, If your immune system is dealing with stuff, it pulls away from a healthy environment that allows cells to grow like they should. So you will see anemias in some patients where it's not clearly identified what the problem is, but they have chronic diseases, and those chronic diseases produce an anemia. A lot of the inflammatory diseases, and I think it's because the inflammatory processes do not promote a healthy environment for cells to grow and mature. Certainly nutritional deficits, so you can expect your alcoholics to have anemia problems because they're not, well nourished like they should be. One thing to consider is that in the older person, some of the symptoms can just be thought to be normal aging, but it's not. What other disease process often is inappropriately or not recognized correctly in adults?
UTIs.
Maybe.
In adults?
In geriatrics, in older adults. That's often thought to be just part of normal aging when it isn't.
Dehydration?
We usually can recognize that.
Memory loss.
Okay, but
Stroke?
we think the memory loss is due to normal aging when it's really,
Due to
Stroke?
we usually pick up on that.
dementia.
How about how about depression?
Oh, I'm sorry, yeah.
Yeah,
I was going.
so sometimes older people truly have a treatable condition like depression, but it gets missed because people, she's just slowing down, she's not as quick as she used to be, and it's depression.
Could it be they also think of it as not as a non-hierarchy of needs type situation? If the person has diabetes or heart issues, they just kind of filter it down the line of issues to where it's number 4 instead of
Right.
maybe number 2.
Right, or even recognize as part of, you can have depression due to chronic illness, namely, the chronic illness makes you feel sad, or you can have depression due to chronic illness because the chronic illness is sucking the life out of your catecholamines and your neurotransmitters, right? That is treatable. We can replace neurotransmitters if we can figure out the right, I don't know anything about psych drugs, except some of their names. Okay, so erythrocyte production, and this is normal, okay? We're going to talk about normal erythrocyte production now. EPO is a glycoprotein primarily produced in the kidneys, a little bit in the liver. You guys know this. And it will increase the number of stem cells that are committed to making red cells. Remember that screen, the slide that showed you the stem cell at the top, and then the first breakdown? Well, giving EPO or having enough epigen in your system will determine that indeed you'll have stem cells that are actually going to travel down that road. And the EPO produced by the liver shortens the time it takes to mature those cells. The lifespan of a cell is 120 days. There are 3 changes that can happen in erythropoiesis. What's erythropoiesis? Production of red blood cells. It is a process. It's called erythropoiesis because erythrocytes is what you produce. Erythropoietin is actually the hormone that stimulates that production. 3 different alterations: decrease hemoglobin synthesis, a defect in the DNA, or you don't have the erythrocyte precursors. Where are these erythrocyte precursors?
All the other nutrients you need to make up.
Not quite.
Bone marrow.
Bone marrow. The erythrocyte precursor is, that line of cells, it's up here. Okay, so we're talking here about a problem with the bone marrow or a problem with epigen where they're not being told to be, to commit. Okay, so that's what that means, erythrocyte precursors. Okay, that's normal erythrocyte production. Now we look at iron deficiency anemia. It is one of the most common one of the most common chronic hematological or hematologic disorders. And you can see here some of the breakdowns. 14% of children under 2, between 1 and 2, have anemia. 3 to 5, it picks up, it gets a little bit better. Look at the difference between, do I have women somewhere? Men, only 2%. I'm surprised I don't have women listed.
Aren't we right there?
Is it there and I'm just overlooking
Just
it?
simple for women, am I wrong? White
that?
women?
That's white women though.
But it's
Well,
black and
yeah, that's
Hispanic
women, yeah. White, yeah, okay, so yes, there it is. Thank you. I was looking for the word.
I thought it was a trick.
No, it's not a trick.
Okay.
I've looked at these, but sometimes, until I actually get ready to use them, I don't see these. No. So men, 2%. Now if we look at women, here we go, there they are. These are white women, ages 12 to 49 years, and there's a 9 to 12% incidence. So clearly higher in women. Black and Hispanic women, 20% incidence. Just something to know, for real. When a person over the age of 65 has anemia, 9% of the time they have GI cancer. And that's what's causing the anemia. The GI cancer is causing a slow blood loss. So when grandma develops anemia, we got to figure out what's going on here. Okay, she might have colon cancer, or grandpa might have colon cancer, and we'll talk more about why that works. Because actually, when you have a chronic blood loss, the anemia you get is iron deficiency, and I'll talk more about why that works. It's not blood loss anemia, because you don't lose that much blood. It's inadequate production because of loss of the iron. Iron is present in all red cells as heme. It's the heme and hemoglobin. The globin is a protein, the heme is the iron. And in the stored form, you've got ferritin. Ferritin is in your bone marrow, your spleen, liver, in your muscles. 2/3 is heme, and 1/3 is ferritin, which is stored in bone marrow, spleen, liver, muscles. Heme gives red cells their color. So if you don't have heme, you have a small, pale blood cell. Most of the iron is recycled. Normally, you lose about 1 milligram a day in stool, sweat, and urine. Not much, okay? The average menses is about 45 mils of blood. Man, it sure seems like more than that. Think about this, 45 mils. Medicine cup and a half, all right? But don't we all bleed for a week or 2 or 3? It seems like forever. I'm exaggerating. But there's the blood in there is only 1.5 mil. Sometimes it's not right. Sometimes women bleed more than they're supposed to, and then they develop anemia. But even that loss, because the iron is replenished, women need iron. Menstruating women should be taking iron supplementation with their vitamins. So these normal losses, so the average menses of 45 mils causes about 22 milligrams of iron loss. So you lose about a milligram a day, and then in addition to the milligram a day, a woman loses an additional 22 milligrams with her monthly cycle. And we have to make that up in our diet. What happens if we don't is our iron stores are going to be used up. And then when our iron stores are used up, then our body can't make hemoglobin. And so then hemoglobin starts to go down. The only abnormal source of iron loss is hemorrhage or chronic blood loss. When the red cell is broken down, remember that picture that I had with the liver? When the red cell is broken down, heme goes to the liver. The iron is recycled. We don't lose iron, except a milligram a day, and about 22 milligrams a month for women. So why do people get iron deficiency anemia? Well, inadequate dietary intake. An adequate diet gives you about 12 to 15 milligrams of iron, but only 5 to 10% of that is absorbed. Your body doesn't do a really good job of absorbing iron. If there's a deficiency, your gut can get a little bit more effective and bump that to 20 or 30%. Does anyone know where iron absorption occurs?
And
One.
In the duodenum, very good. Happens in the duodenum and the upper jejunum. So any surgery that removes that or bypasses that is likely to produce an iron deficiency anemia. Now, in someone who has a chronic blood loss in the GI system, it takes 50 to 75 milliliters of blood to make your stools appear black. What's a black stool called? Melena. But it takes a good amount to make that happen. So someone who has a chronic blood loss from a cancer they may develop an iron deficiency anemia, but their stools don't really turn dark. Certainly, if there's no good reason for someone's stools to be black, what would be a good reason for someone's stools to be black? If they're taking iron, okay? But if there's no good reason for someone's stools to be black and their stools are black, that needs to be investigated.
did you say 55 grams or milligrams?
No, milliliters, mLs. Yeah. In a chronic blood loss, and you may have already made this connection, when I said average menses is 45 mils and 22 mils of iron is lost. So that means that every 2 mils of blood has a milligram of iron in it, right? So if you lose 2 to 4 mils a day of blood, 2 to 4 mils a day of abnormal blood loss, that's not much, right? You'll never see that in the stool. That can result in an iron deficiency anemia if it's happening every single day, because the iron that's lost exceeds what is provided in the diet. So if we look overall at iron metabolism, I suppose, iron is recycled after macrophages in the liver and the spleen phagocytize the older damaged RBCs. And then the iron binds transferrin, where it is either stored or sent to help make more red cells. So we get iron from our diet and from supplements. We get it from recycled red cells. It's transported by transferrin either to a storage place or to make red cells. The only loss of iron is a little bit that has to be supplemented by the diet. But everything that's in the hemoglobin, you get 2/3 in the hemoglobin, 1/3 is stored. Okay? All of that is recycled. Your manifestations, you're going to have, first of all, general manifestations of anemia. We've kind of talked about those. Pallor, paleness, is the most common finding of an iron deficiency anemia. And then the atrophic glossitis is the second most common. And that's because of the actual iron deficiencies in the tissues. You do have iron in your tissues. Okay. Dysphagia can happen because of, again, lack of iron in the tissues, as can brittleness of hair and nails. And does anybody know what cheilitis is? Inflammation of the lips. Those are symptoms of iron deficiency specifically. If you look at the lab findings, you will see hemoglobin, hematocrit, mean cell volume or corpuscular volume. The mean means average. Mean doesn't mean mean means average. Mean cell hemoglobin, mean cell hemoglobin concentration. Those are all low. Reticulocytes are what?
They're gonna be high.
Oh, sorry.
Well, I've got to think about this a minute.
I guess it depends on the reason.
They're going to be high. Well, it's going to depend. They're high. The reticulocytes normally, no, they're low. I'm sorry. In iron deficiency, they're low because you can't make the reticulocytes. You need the iron to make the reticulocytes. They're going to be high in places where you make the reticulocytes, but can't mature them. Normally, and reticulocytes are immature red cells. Normally, they're less than 1% of the total red cell count, but they're down in anything that is a production issue, iron deficiency, anemia in particular. Now, the serum iron, I think I have a slide that shows this better. We won't go there. Then they're going to look at stool guaiac, because we're looking for a source of the blood loss in an iron deficiency anemia. It could be nutritional, but depending on the population, the age of the person, especially if it's an elderly person, we're going to look at making sure they don't have a cancer somewhere. What's a stool guaiac? Yeah, you're testing for blood in the stool, and the blood in the stool will show up. You put it on a card, they put this dye on it, and it shows up blue if there's any blood in it. And the stool can be as brown can be. It can be very normal appearing and end up with blood in it. Then if that turns up positive, then they'll try to look for a source. The cells on the left are a patient who's got iron deficiency anemia. They're microcytic and hypochromic. On the right, you've got normal cytic, normal chromic. What's chromic refer to?
Color.
Color. See the difference? All right, the panel on the left shows your normal serum levels of transferrin, iron, and ferritin, kind of in arbitrary units. There's not, I don't have, they're more related to each other is what we're looking at. So you can see that in normal, it kind of looks like, like that. And in a deficiency, in an iron deficiency anemia, one of the things the body says is, not getting enough iron. Wonder if I send more cars out, if I can get more iron. That's what transferrin is. Transferrin is a transporter. So that's why the transporters go up. Is that helpful? No, it's really not. But the body sometimes doesn't know, what to do. It doesn't quite grasp where the problem is. So it sends out more. Can anybody give me another example of when the body sends out more transporters because there's missing passengers? Say again?
Insulin,
Insulin. I'll have to think about that one.
pancreas.
I understand what you're saying. The tissues aren't getting sugar, and so the pancreas kicks out more insulin when the problem is the cell wall. That's an excellent example. The one I was thinking of is COPD. If I don't have oxygen, my body makes more red cells. It sends more cars to the lungs to pick up the oxygen that isn't there because it thinks it might help. It doesn't help, but that's kind of what's going on here. If the body doesn't have iron, and if it has the ability, then it will send more transporters. And then obviously the iron's low, because that's the problem. And then the stored iron is also low, because the stored iron goes first before the serum iron goes. Does that make sense? The goal is to treat underlying disease. So is it nutritional? Then we need to increase the intake of iron. You should know your iron foods, things like organ meats, liver, eggs, dried fruit, and legumes. What's a legume?
Peanut.
A peanut is a legume, yes it is. Can someone name another one? Say again? Soybeans. Most of your beans, not your green beans, but most of your, I have yet to describe, I have yet to find a word that is beans but not green beans. So that is it. Beans but not green beans. Those are predominantly legumes. And then green leafy vegetables tend to have iron in them. Whole grain and rich bread, cereals and potatoes, those are considered some iron foods. Oral or occasional parenteral iron supplementation. And if the anemia is significant enough, then the patient will get transfusions. Now, oral iron, pretty darn inexpensive, pretty convenient. We know that it's going to be absorbed in the duodenum and the proximal jejunum. So what do you think about an enteric-coated iron? Doesn't make much sense, okay? It says right there, what do you know? Acidic environment promotes the best absorption of ferrous sulfate. Give me an example of how you can promote an acidic.
Take your iron pill with orange juice.
Take your iron pills with orange juice, yes ma'am. Anything else?
Don't take what they
Take it
need.
before meals.
Say again?
Yeah, it's take before meals and
Yeah.
don't take with antacids.
Yeah, don't, no, absolutely not with antacids. Not only does antacid mess up your iron, antacids bind the iron. So it's worse than just diminishing your acid. What about the PPIs? The daily PPIs that our patients take?
They should take the iron before that, because the PPI, that proton pump inhibitor will drop the acid, which
Yep.
will make the iron.
Yep. And you will find that it's not uncommon at all for the patient's iron and PPI to be scheduled for 9 o'clock. And when you bring me those meds, I'm going to say to you, you really giving all this together like this? Well, it's ordered like that. Okay, so how about you give all these and put that PPI in your pocket for an hour? And that's what we do. If people are thinking, and sometimes I will send a note down to the pharmacy that says, please schedule the iron for 8 o'clock. Because it's better to have iron with breakfast while the stomach has still got some acidity thing going on than it would be to give it with the PPI. Not everybody can handle iron on an empty stomach. So we have to be, considerate of that, because if I'm going to throw it up, I'm not getting anywhere. Even if I decrease iron absorption by giving it with food, if I have to give it with food and I can add some orange juice, that's better than having the patient throw it up. I never could do the prenatal things on an empty stomach. That was the one thing that would make me nauseated. If it's a liquid iron, you want to be sure that it's diluted and ingested through a straw. Why? It stains the teeth. Any ideas as to why you might have to continue therapy after the hemoglobin returns normal?
To replenish it?
Yes, you've got to replenish your iron stores. The iron stores were the first to go, so just because the iron is normal, you still don't have iron stores. The dose or the type of iron can be changed if the patient is having side effects. Constipation is more common than diarrhea. It's usually constipation. So it's not inappropriate at all to consider that the patient may need a stool softener to deal with the iron. There is a difference in how much iron there actually is in these various formulations. Ferrous sulfate is very common. 300 milligrams 3 times a day, an hour before meals, gives you 20% of an elemental iron. So 20% of the 300 milligrams is iron. So that would be 60, 60, and 60, right? 180 milligrams would be elemental iron. The rest is stuff it's bound to. A lot of people can't tolerate ferrous sulfate because of the sulfate base in it. There is a form that's broken down a bit that has more iron in it, but it's probably more expensive. Now ferrous gluconate is more tolerable, but it doesn't have as much iron in it, elemental. And then ferrous fumarate is 33% elemental iron.
When you're talking about the ferrous sulfate and the 20% elemental iron, are you talking about 900 milligrams?
You know, I didn't do that right. Yes, I was talking about the daily dose, the daily full dose,
Is
because
20%.
it'd be 60 milligrams per tablet.
So the 20% is indicative of the of the 900 milligrams that will be taken, or of just one dose?
Well, the 20% would be 20% of either way, either each
Yeah.
pill, or when I said 180, I said this was going to be 3 pills a day.
Okay,
So I went 20% of 900.
okay.
So either way, it's still 20%. Okay. Parenteral iron, iron sucrose. Usually we give a 2-minute bolus. This, if I'm not mistaken, is the one that they use in dialysis a lot.
Yep, that's it. And you want to give it towards the end of the treatment if you can, because it can clot up your system.
Really, so they give it towards the end? Okay.
Try to, yeah.
Or it can be given as a short infusion. Ferric gluconate, you've got dose recommendations of around 125 milligrams. Iron dextran has being replaced by ferric gluconate and iron sucrose. You don't see this one too much. The iron dextran required a test dose because some people would be quite allergic. It's been a very long time since I've seen iron dextran. And then there's a new, well, relatively new, approved in 29 that can be given very quickly, that provide pretty high doses of iron and can be given in a couple of injections. Iron can stain the skin if it's being given IM. So you want to make sure that you use a separate needle to withdraw and a separate needle to inject and use C-track. You also want to make sure you have like a 1/2 ml air bubble to really clear the needle and get it down and out of there. Your at-risk groups for iron deficiency anemias, here's a list of those folks, and they should make sense. Okay? If it's a nutritional issue, a blood loss issue. Okay, this is probably a good place for a break. So let's go ahead and take one.
Is that the railroad?
Mhm.